Thanks very much. Next, we have Richard Hahn.
Hello, my name is Rick Hahn, and I'm a professor of computer science at CU Boulder. We've been working on an idea called the self-wrapping active bandage. This idea came out of a robotic materials workshop held at CU Boulder, including Stanford, Berkeley, and others. And so the idea here is to demonstrate the feasibility of a self-wrapping active bandage. And so this thing would sense the dimensions of a limb that it's put on, and also the extent of the wounds, then automatically self-wrap to cover the correct area and tighten to the correct degree. And so, as you can imagine, there are a lot of challenges here. It has to be accurate in terms of coverage. It has to be safe in terms of the amount of pressure that it's providing. It has to be reliable, automated, hands-free, ideally wireless, fast, strong, low cost, and lightweight. So a ton of challenges here. And so we imagine, in terms of the technical approach, that we're going to need a sort of novel, multi-layered robotic material with embedded distributed actuation, sensing, computation, and wireless communication. And so this is going to require innovations in a lot of different areas, 3D self-localization of the bandage as well as the wound, sort of 3D distributed wrapping control algorithms. We need safety algorithms so that the bandage doesn't tighten too much or too little, but just the right amount. And so this will probably involve some machine learning. Robotic materials sort of sits at the intersection, sort of interdisciplinary between computer science and materials science. And so we think there's going to be a lot of interesting new work in sort of integrating these two areas, as well as the different subsystems involved. So this is an early we've been working on this for about a year, and we have a self-tightening prototype, which we show here on the lower left. And as sort of shown here, we've just been experimenting with, can we understand what the challenges are for the full self-wrapping vision over here on the lower left. And so this is just, we call it self-tightening. We've been testing the control algorithms. We have mechanical actuation that will pull multiple strands of different fabrics tighter so we can provide differential pressure. We have strain sensors that from which we infer the amount of pressure. And so this has all given us some clues about sort of what are the challenges that are going to be coming up when we go to full 3D sort of self-wrapping and that kind of thing. And so, we've been, in terms of outcomes, we imagine that this will be useful for first responders in sort of those early few minutes. Instead of spending all that time trying to wrap a bandage around someone, we can just slap this on there and the self-wrapping bandage goes off and does its thing, and frees the first responders to, collect vital signs or communicate or do other things. We also imagine that this could have some usage in sort of deep vein thrombosis, but since this is in the early stages of experimentation, we're looking for medical collaborators and as well as engineering collaborators to help us refine the medical application scenarios, define the medical design goals for these scenarios, help us perhaps test a prototype in some sort of lab setting, and ultimately submit to DARPA, NSF, or NIH. Thank you very much.
Thank you. Next, we have Robert MacCurdy.
Hi, yeah, I'm Rob. I'm an assistant professor in mechanical engineering at CU Boulder. The problem that we're trying to solve here is that our ability to gather volumetric data from patients, I would argue, outstrips our ability to actually visualize those data. So with MRI, CT, and volumetric acoustic scan technologies, we get this map of these dense tissue distributions, and yet our ability to see that map is limited. So the upper image shows a slice of some scan data from a patient who has a third ventricle brain tumor. And the typical approach is to scan through those slices in a computer visualization approach, and then try on the surgical side to, in the surgeon's brain, integrate that slice data into a volumetric representation. There are newer techniques that allow holographic, other kinds of three-dimensional visualization tools, and yet the surgeons tell us that they want to have a tactile sensation of what the actual structures that are represented by this scan data look like, feel like, how they interrelate with other structures. All of those pieces of information are important for the surgeons to kind of plan their attack because every patient is different. So for that reason, a single sort of pre-planned model would not work, they tell us. Instead, we need to have a tool to turn scan data from the individual patient's situation into a tactile model that the surgeons can manipulate. And so for that, we turn to 3D printing. It's a relatively recent development that in 2019, I think it was June of 2019, 2 AMA CPT codes were created that actually allow billing for 3D printing to occur. And yet the current technology in 3D printing creates static models that cannot be manipulated. In some cases, those models can be transparent so you can see through them. And so the ability to rotate that model is slightly better than looking at a computer representation. But what would be much better is to actually create models that had a higher fidelity mechanical representation of the actual tissues. And so what we're working on in this project is to develop algorithms and material mapping to enable the printing of physically plausible three-dimensional representations using today's 3D printing technology. We're not proposing that we're going to create individual materials, at least in this work, individual materials that are exactly identical to the tissues that are in the patient. Rather, what we're going to try to do is to create combinations of existing materials that can approximate the differences between materials in a way that's salient for the surgeons. So we're bringing together some team members from CU Boulder who are experts in biomedical devices, biomechanics and materials, and folks from Denver who work in computational design. You heard from Nick Jacobson just a moment ago. The initial steps are to do mechanical characterization of these materials, and then to push that further to design data-driven models of those materials, then invert the problem so that we can, when we know what kind of material properties we want, we know what distribution of materials we actually need to create in this volumetric voxel-based design. It's a big market and it's growing fast, and so we think that there is commercial relevance for this as well. We're already seeing in the 3D printing space that the patient outcomes are dramatically improved when presurgical planning models are used. Thanks.
Thank you. Next we have Courtney Welton-Mitchell.
Hello, thank you. I'm Courtney Welton-Mitchell, and I'm a social psychologist. And for the last 8 years, I've been working at CU Boulder in research with the Institute of Behavioral Science and the Natural Hazards Center. And then a few years ago, I joined the Colorado School of Public Health on the Anschutz campus. So today I'll be talking about a project that some colleagues and I have put together. We are a relatively newly formed team, so this project hasn't been funded to date. But I'm presenting on behalf of myself and Dr. Charlie Little, as well as Total Worker Health colleagues, Dr. Lee Newman and his colleagues. So we're interested in looking at the influence of risk perception, leadership credibility, and mental health on compliance with personal protective equipment among healthcare workers during COVID-19. I think it's particularly important to determine what factors might influence this compliance among hospital staff, because we know that they're at high risk for contracting COVID-19. And it might be surprising to some people to realize that, of course, the PPE is provided, the guidance is provided, but it appears that compliance is actually quite variable, related to understanding the use of various types of masks, gloves, gowns, head coverings, and face shields. And in part, the variability might be attributed to changing guidance from various levels of hospital leadership as well. So we know emerging evidence in other settings suggests that safety behaviors can be influenced by risk perception, perceived credibility of leadership, and various mental health factors. And so we plan to examine these relationships in a hospital setting among nurses working on COVID positive and COVID negative units. So our technical approach is essentially with the methodology. First, we'll examine hospital-based PPE communication materials and associated trainings. We'll also conduct some focus groups and interviews with key stakeholders, hospital leadership, members of the PPE task force, and that will inform an online survey development. And this will be an online survey, time one, data collected from a representative sample of 500 UCH respondents. That's 250 nurses working on COVID positive units and 250 working on other units. And again, we'll measure the variables that I mentioned around risk perception, perceived credibility of hospital leadership, mental health, and safety behaviors. Now, something like compliance with hospital PPE guidance, as you can imagine, would be vulnerable to misrepresentation on self-report. So we'll actually have a variety of different ways that we'll be measuring that, including a response to case-specific vignettes around PPE compliance under particular scenarios. So this proposal integrates essentially the social science research expertise and my background in social psychology linked to the Institute of Behavioral Science and the Natural Hazards Center with a high-risk clinical work that's happening at Anschutz, particularly, and drawing from Total Worker Health, but particularly from my colleagues in emergency medicine. Again, Dr. Charlie Little, who would be co-PI on this project, IBS, and then in the School of Public Health, Environmental and Occupational Health, Center for Health Worker and Environment, and Department of Biostats and Informatics. We have already been in touch with all of these various colleagues to form the team for this project. And then the proposed funders would be for an expansion of the project and for time 2 and beyond, NSF Rapid with DRMS, NIOSH R21, Disaster Science Responder Research Program, Russell Sage Foundation grants are similar. And essentially the benefit of this project is that it has myriad of applications. So it will illuminate factors that influence compliance among healthcare workers, compliance with PPE among healthcare workers at a time when adoption and adherence is critical to worker safety. It will assist decision makers in understanding how to mitigate risk of contracting COVID-19 among hospital staff by addressing barriers to PPE compliance. And it has the potential to influence hospital messaging campaigns, leadership approaches, and programs designed to promote mental health and well-being as a path to increasing PPE compliance. Thank you.
Thank you. Next, we have Aubrey Schick.